Good afternoon, everybody. Thank you for attending. I'm just going to introduce Anu and then we can start the session. Anu is a clinical manager at Promesia, and she has been in ICU leadership roles, moved to New Zealand in 2018, and has been advocating for the well-being of older adults since. She's got a key interest in end-of-life care, pain management, mental health in aging, and also clinical education, and is doing a postgrad in nursing. So at the end of the session, there will be a question and answer portion. But if you have got any questions along the presentation, just use the chat box, and yeah, we'll answer the questions along the way. And I'll pass on to you, Anu.
Thank you, Rabika, for that introduction. So today's session is on recognizing and responding to deterioration in aged care. Before we start, we just want to look at some statistics which show what exactly is happening in aged care. So in New Zealand, we know that we have a very rapidly growing aging population. The number and statistics show around nearly 100,000, 90,000 Kiwi, New Zealanders living in residential aged care facilities overall, and 15% of the New Zealand population is around more than 65 plus years. So it is expected that it is going to increase. If you look at the graph, it shows how the population of elderly is actually increasing, and you can see the distribution of different ethnicities is also actually rapidly increasing throughout New Zealand. So there is an preventable factor that we can see that we have Maori and Pacific elderly face 2.5 times higher rate of preventable deterioration from the current statistics, and rural areas actually always have challenges of reduced critical time in terms of responses because of lack of accesses or staffing shortages and things like that. And as we're already in aged care, you know that there is a bigger number of ratio in terms of staffing. So like in the daytime, if we have 1:8, in the nighttime we have a 1:20, which is quite a higher ratio or expectation that the staff needs to monitor. So what are the current challenges? The current challenges are that even when we see into aged care, 60% of residents that come into aged care have some form of cognitive impairment. So that definitely always is something that we need to keep at the back of the mind when you're doing some assessment or checks. Increasing complexity of care needs multi-morbidity. That means that, when we have these challenges, we need to have better skills and better knowledge and multi-speciality experience to identify these changes quickly too. Rurals always have challenges in terms of specialists, and there's always a higher turnover in aged care, which is never new. So going forward, what are the key signs of deterioration? So I have just divided into three main parts, but one is physical indicators. So there are certain signs we know even from before they are actually happening on the floor level. So some of them are unexpected weight loss. So if you see someone having a rapid weight loss of more than 5% in the first 30 days, then that's something that you know is already happening, or there's a deterioration that's happening in that particular resident. Sometimes mobility is one of the biggest factors. If you see that there is an infection ongoing or there is a change, then there's always decreased mobility or changes in balance, or you can see the number of trends of falls increasing in the facility. Changes in vital signs, which are very critical. So absolutely that, there could be a lot of changes in terms of vital signs, like drop in blood pressure or changes in pulse or temperature. These are critical values for us to monitor. We have already seen that increased falls or near misses is kind of a starting indicator that there's some changes happening. Sleep pattern disturbances. So if you see someone who is sleeping well has suddenly not sleeping, or there's changes, then that's kind of an indicator that there are changes happening. New or worsening pain. So if there is changes in pain, then yeah, that's something that we need to investigate. Other than that, the second thing I've taken is cognitive indicators. So when someone is losing their cognitive ability, there are some changes. This could be confusion or a short-term memory loss, difficulty in finding words that they usually connect or talk to, withdrawal from other activities, or even if there is changes in their pattern of attention, then it is kind of a sign to say that something is not right in them, which is always happening well. Emotional and behavior, it's similar to cognitive, but mental health is very important. And sometimes it's an area which we do not pay much attention to. So in terms of mental health, if you see that someone is becoming very socially withdrawal, but other than that, also having a lot of agitation, apathy, unexplained crying or anger, or, someone is not paying much time and attention to their own personal care and hygiene, lack of emotional values, changes in their food pattern, increased anxiety or distress, all of these can be seen as key signs of deterioration in a slow progression way. The good part is, if you recognize these signs early, we can prevent hospitalization or their serious complications coming forward. Risk factors. As aged care, we are already having a very vulnerable population. So medical risk factors, it's endless. But I've just listed few, like especially anyone with heart failure, COPD, diabetes, and with polypharmacy, using a lot of medications, then they would always have a risk of deterioration. Social vulnerability. I think it is very important to understand that home is always the best place, and sometimes even residents moving away from home, from their loved ones, make them really vulnerable. They feel really very low in mood, not wanting to engage, and there are other barriers like not having access to funding, low socioeconomic status, lack of family advocates, and not having a family support. And if it is also someone who doesn't understand English, or having other languages, then that social vulnerability just increases the vulnerability of the whole complexity. The last one I've put here is cultural. So definitely studies have proven that Maori residents have always not had that connect. They had always had the disconnect and had those challenges of cultural considerations in the community in the overall. Deterioration and early warning signs. So what are the best tools? So Health Quality Commission, Safety Commission has come up with certain tools as indicators that will help us sort and identify these. So use of deterioration early warning scores is called the DEW score, which is actually something which is currently in the standard and which is actually been under testing phase by the Health Quality Commission. So the first things are that monitor the 6 key vital parameters, making sure you have numerical scores based on measurements to identify where is a priority, triggers response at specific thresholds. So they've put certain markers and indicators. So when you more around the threshold, then you know that you have to escalate. This was implemented in New Zealand aged care facilities around last year, and for reduced hospitalization was proven from the studies. So I've got a flow chart here. I'm having a difficulty in moving to the next slide, but I hope it will go through. So, deterioration and the early warning score. So they have brought in certain systems, like 3 different systems. So the first one is the quick views. So the quick views means that the first level of screening is done by the healthcare assistant. So the healthcare assistants are the ones who are at the bedside every day in aged care. They play the responsibility of being the first screening. So screen for changes that may include acute deterioration. If they see any changes, then they trigger the referral to the RN for further assessment. Then the second chain comes when the training assessment is done by an RN. So here, it's very important that the nurse who's attending the shift, the first level nurse who's doing the assessment, does a complete clinical assessment. You have to estimate and put it into a triage where you assess and understand the clinical urgency of that situation, and provide an ARC facility standardized intervention and escalation pathway so that this can be escalated further. The next one, lastly, is your ISBAR dues. There is a big emphasis on use of ISBAR in healthcare systems so that there is critical thinking, there's use of proper terminologies, and making sure all the information is passed to the next stakeholder you are communicating to. But you can see the user here is again the nurse. So it's again the nurse in the front line who's paying that big responsibility to support that RN's critical thinking. So you can escalate this to your next level nurse. That could be a clinical manager, team leader, your unit coordinator, or your nurse practitioner who is in your facility. Communicate your assessment, record a plan of action, and take it to the next situation. There's a beautiful flow chart. I really loved how this flow chart is. I've just tried to squeeze it onto the screen. But as I said, and we discussed now, the first level of the shift assessment is done by the HCA. So if there is any clinical indicators that is of worry, if there is none, there's nothing to worry. There's nothing that is escalated. But if you see, for example, resident is drowsy, which is a new sign, then the first level of escalation begins to the RN. The RN needs to begin the use assessment and then score it from above. Okay. If the score is 0, then you don't have to do anything. But if the score is above 0, then you have to follow the support pathway. So take a pause, engage with your HCA, and start your monitoring. So your monitoring will include making sure you do a full check of that person, cognitive assessment. If it requires GCS or neuro-obs, then you do the neuro-obs. If it's vital signs, then you do a full vital signs. Look at the consciousness of the person. And if you think there's anything that's going into a high alert or a red alert pathway, then you need to start using it. So use your ISBAR DWIS, think critically about the event, and communicate with your emergency provider. That could be a GP, it could be an NP, or it could be an ambulance crew, whoever it is. Then a conversation with the family, which is very important. I think this is the most missed part, is communicating with the family. Okay, make sure you have those clinical conversations with family or your decision maker who is an EPOA. Begin the treatment. So even when you're waiting for your next level of instructions or your command, make sure you always connect with your care plan, start your short-term care plan, make sure you put your neuro-obs. For example, if it's a fall and the person has confusion, make sure you have your neuro-obs pathway started, make sure you have your short-term care plan for your fall begin, make sure all your documentations are tight so that you have your monitoring systems in place. If the resident recovery is underway, and you see there's nothing more to do, if it's like, for example, you have assessed it, there's a critical situation, but there's nothing more to do, like he is gone to comfort-based cares, then you can safely stop your use and say there's no more to do. But if you think that he has more monitoring to be placed, then what you do is you go to the next level, that's a stop and watch tool. So I have taken all of these from the HQSC source on the website. So all these informations are available there. So what is stop and watch tool? Stop and watch tool is like an early warning tool for the non-clinical staff especially, which the nurse has to put so that they can identify any concerning changes. So stop and watch. So just as the acronym says, S is for seems different than usual. So it can be anything. Something that is not in a baseline and he's behaving something differently. Talks or communicates less, overall needs more help, pain new or worsening, weight changes, agitated, feeling a bit tired or weak, or changes in skin or condition, needs help with walking or transferring when they were usually doing better, or it needs that if they're needing help with toileting, more than usual. So how do you create an effective response protocol? First thing is always identification. So you see that the pathway, the first scope is always to the RN. Okay, so the first pathway of identification sits with the person who is identifying it. It could be a HCA or an RN, but when you identify that, use your assessment tools and clinical judgment and put it in your severity rating. The second part is primary response. So if it's a HCA who's doing the identification, then the RN is the second response. If it's the bedside RN who did the identification, then your senior nurse, it could be your clinical manager or unit coordinator who will be doing your severity framework and modifications. The most important thing, do not sleep over the problem, escalate it. Escalate it to your next GP, after service, to your nurse practitioner, whoever is assigned, so that you use ISBAR. Make sure you use ISBAR. This is something I always emphasize, that you use an ISBAR format, and escalate it to your charge nurse, your team leader, or your clinical manager, or your nurse practitioner immediately, so that you know that you have attended and identified the deterioration and actioned on it. The last part is definitely emergency response. If you think that person needs to be transferred to acute services, make sure you escalate it. Do not sleep over it. Do not put it for later. Especially with elderly, things can progress quite fastly. So make sure you take your emergency response and always notify your family. Okay. Few effective protocols is when you know there is a deterioration, look at your staffing and assign someone to closely monitor that person. Okay, revisit your staffing so that it is busy, but make sure you take the changes. Make sure you document every changes in that person. Communicate templates for consistency. So I would always say use your stopwatch tool, use your ISBAR so that you know that you have actioned those steps. Okay, regular protocol review. So if you think things are not working, then protocol. There are a few more advancements. It's like nowadays, everybody is moving to AI. So there are electronic health systems. So if you know someone is wandering, you can use a tagger to watch them. If you have someone who needs monitoring 24/7, then you can look at remote monitoring systems that can detect every manual checks and changes. AI-powered analytics, this is something that is in study, that we have predictive algorithms in place that identify that a person is deteriorating or this is how the person's journey is going to be. But among all of these, even though this technology is there, the most important thing is staff training. Nothing in this can change or replace staff. We need to have the skilled, knowledgeable staff on the floor to identify these early signs of deterioration. So the most important thing is, as nurses, we need to train and support our systems. So making sure we build those observation skills, building those cultural competencies, understanding ISBAR, documentation are the simplest factors involved. And support system, again, is mentorship, making sure your nurses are very well aware. You have simulation exercises, so trainings that if there is a fall that's happening, what would you do? How will you action that situation again? Debriefing sessions, peer support, and also having gerontology. Okay. The recommendations is always you have new changes happening regarding deterioration and early recognition. Please follow the Health Quality Safety Commission's website for all the latest updates. There are a lot of research and information. So these use protocols, monitoring will mandatory implementation timelines will really help and assist in ensuring that you have a 100% implementation of the process. Develop funding models that will help in recognizing these, create quality indicators specific for deterioration so you can make sure you meet it, mandate minimum staffing ratios. So if you see that, for example, if it is a D6 kind facility where you need higher staffing, make it mandatory so that there's a higher risk of safety or deterioration. Or if someone is on a hospital level care, make sure the staffings are revised based on the need. Invest in integrated health commission in information system between aged care and hospital, and always connecting with hospitals. Keeping that good link with hospitals will help you de-escalate when you need in an emergency situation. Practice improvements, making sure handovers. Sometimes a nurse in a shift A identified that someone is deteriorating, having high fever, but that information is not passed to the incoming nurse. This is a risk and is an ongoing issue in healthcare. So making sure we have good handover systems and tools for monitoring. Establish resident and family education programs on recognizing changes. Create facility champions for deterioration prevention. Develop a community of sharing these practices and debriefing after any issues are happening on the floor. Call for a quick huddle. Look at things that really went well. Look at things that need to be improved. Design and tailored approach for resident and communication barriers. We understand that, aged care is growing with IQNs and international qualified nurses coming from outside. So it is a challenge sometimes. Communication can be a barrier. So using ISBAR formats really help us preventing these issues. So work towards always early detection is early prevention. That's all. Do you have any questions? No questions to ask? That means you understood everything. But if you need the templates for whatever was in the presentation in terms of your, the due score that is coming, it's still in the framework. All the information is there. There are standard templates that are available in the HQSE website, which will be really very useful. I can actually pop it through for anybody who wants. If you let Rebecca know, I can send that through for you to see as well.
Lucy has got a question. What are the staffing ratios for ARC?
There is no standard staffing ratios in place. It is mostly currently what we're doing. It is more of organization based. Certain organizations review based on their premium facilities or their establishments. It is always fluid, but as per the best recommendations in aged care for hospital level care, it is between 6 to 8 at least in morning hours. But again, it's shift based. Some facilities have dual RNs and keep HCAs low. Some people increases level 4 or medcomp and increase staffing. So it is actually organization based. But if you have high acuity residents, especially in hospital level care, for example, if you have a 25 bedded hospital beds, but your hospital level residents are more independent at that time and don't need closer monitoring, you can always revisit on your staffing. But if you see that most of them are palliative, end of life, or bedridden, there is a real need that you increase and look at your staffing. Sometimes you might in your dementia in D3, you're waiting for a D6 bed, and you have opportunities where you can discuss with your portfolio managers and ask for increased staffing and funding. So they will give you a short-term funding for that period of time because you have a high acuity resident in your dementia rest home. It's not for your long term, but to a period that person sources a bed in a facility. So, there are things, this is a rapid, always robustly moving process, and it is based on your clinical acuity of your place. Few industries, the top leading organizations already have a staffing calculator, which is always worked on a daily basis, where you put in your number of acuity, number of needs, number of staffing, and then you reassess based on needs. So I wouldn't have a straight answer, but it is a daily working process.
What is the staffing ratio during night shift for hospital level care with 26 hospital level care beds? I think just with what Anu said, there's no anything set in stone. Even in the ARC agreement, it is just saying that it, as long as there's safe staffing level. Yeah. And if you have hospital level of care, there should be a registered nurse coverage for every 24 hours. So the recommendations are quite flexible in that sense, and it depends on, like Anu said, the acuity of the residents and also the organizational policies and resources that they have. So there's no and where did you get the best practice ratios? And who has the staffing calculator? Do you know anything about that, Anu?
So staffing calculator in every industry is different. For example, organizations like Ryman, Questrel, Somerset, all these management profiles, we use our own staffing calculator. So even in when I was working in Radius, so it's not something that one person decides. So there's a team. So it's a team of regional manager, quality manager, facility manager, and clinical manager who have accesses, and we put a daily occupancy. And based on these occupancies, it generates your acuity, and from the acuity creates your staff needs. As I said, to coming back to the hospital level care, there's only one recommendation which is mandatory in a hospital level care, is that you need to have an RN full time on the shift 24/7, including nights. That's the only requirement for a hospital level care, which is not a requirement for a rest home. So, you might have rest homes that are running with HCAs or level 4s full time, but you might have an RN in the morning hours. So again, it is very important that level 4, if it's in the night without an RN, that organization or that facility will have a policy that level 4 nurse, or that level 4 HCA has access to on-call or virtual RN availability on site to support. So that is the recommendation. And recent ARC has actually also included teleconsultation as one of its criteria. So you will always have teleconsultation available as well, which is as established as accepted, which was not accepted before. That's only the recent change in it.
Can you talk about how to measure the effectiveness and compliance of the due system?
If you go down to the Health Quality Safety Commission report, there is a report that has been just released 2 months back. So in 2024, the Health Quality Commission had implemented due system in about several facilities, and they have put out an outcome. The outcome definitely shows, as I put also in my report, that 33% of hospitalizations seem to have reduced. So the further implementation phase and ideas have still not come out. That's why I did not also put out a due scoring chart, but there is a template that has already been put in the report. So there is, I can actually quickly try to pop back and show you the website, because I think I have those pages open. Rebecca, is the screen seen? Yeah, okay, perfect. So this is the feasibility study report from aged care, residential care. It is available for easy access for everybody. So this is the implementation they did last year. And if you go down to the health quality website, so it is in the post-evaluation phase from May to August. So I cannot give you further outcomes unless the outcomes are out. It is still under study process, but you will have all the information on your health quality website on how the effectiveness is. It was planned and prepared last year, and the testing happened in October 2025. I did read the evaluation report from April 2025, which was there, and the post-evaluation is actually happening right now. And I don't think I have the final report of it yet, but there is a study report of what it was, and that is what I have actually prepared for this presentation, because that's the latest update. But the most important facts.
Were you sharing that dues the due about the dues, or is it just your presentation? Because we only can see your presentation.
Okay, yes, I was sharing about the dues actually. This one, the flow chart.
So you can still see that.
Hold on. I can probably stop sharing and share again. Give me a second. Can you see this now? Yeah, sorry. So I was actually showing the Health Quality Safety Commission website. So, so this is where the feasibility study started in aged care. It is actually new, because we see that there's a lot of shortages and shortcomings in aged care, and we really want to recognize these signs early. So the Health Quality Commission had prepared a planning phase last year. This was in the March to May 2024. So the final evaluation report had come out in April 2025, but the post-evaluation is still not out. So we do not have, complete feasibility, but there is a feasibility study already on the website, and the information we shared is the latest, that is in August 2025. So this is the flow chart which has been provided in the report, which I put in the presentation as well. And I think it's very useful, especially because the first level of responsibility falls with the healthcare assistants and our caregivers to make sure they are aware how critical every day of their assessment is. And that is something which is a take-on message for all of us, that recognizing of early deterioration signs very much start with our first line workers, which is our caregivers or our nurses. And the evaluation and how many sites were signed, there are detailed reports on this report for whoever. I can also download and send it through if you're interested.
Does anyone else have any other questions? Okay, thank you, Anu. So just all the links and the presentation will be up on the ACA website. And yeah, thank you very much, everybody, for joining. Thank you very much, Anu.
Thank you so much. Thank you for having me for the presentation. Have a good afternoon, everyone. Thank you.